And with me, I have Dr. Rani Banik, who is a board-certified ophthalmologist and fellowship-trained neuro-ophthalmologist with additional training in functional medicine. Dr. Rani focuses on the root cause of eye diseases and uses integrative strategies for conditions such as thyroid eye disease, macular degeneration, cataracts, dry eyes, glaucoma, as well as other diseases of the visual system. And her treatments are based on nutrition, botanicals, lifestyle modification, essential oils, and supplements. And Dr. Rani runs a private practice based in New York City, in Manhattan. Is that correct?
That is correct, yes.
All right. And also an associate professor at Mount Sinai in New York City, where she serves as an educator and researcher. And Dr. Rani also is frequently featured as an expert in the media and has been interviewed on a lot of different places. Good Morning America, CBS, NBC, ABC, New York Times, Washington Post, Fox, and a number of others. Dr. Rani has been voted as Castle Connolly Top Doctor and New York Magazine's Best Doctor in Ophthalmology every year since 2017. All right, well, thanks for joining me, Dr. Do you prefer me to say Dr. Rani or Dr. Banik?
Dr. Rani's fine. And thank you, Dr. Eric, for that kind introduction. That was wonderful. Thank you.
All right. Well, you are very welcome, Dr. Rani. And all right. Well, I'd like to start out by asking you just to explain to those who are unfamiliar with the difference between, let's say, an optometrist and an ophthalmologist, and then also a neuro-ophthalmologist. So if you could kind of explain the difference between the three.
Sure. So many people don't realize that there are various different O's in eye care. So there's ophthalmologist, optometrist, there's also optician. So what's the difference? Well, an ophthalmologist is a doctor who has gone through medical school and then done an internship and residency in ophthalmology, and some of us have done fellowships as well. And an ophthalmologist treats eye diseases both medically and surgically. And we also do prescribe glasses and do additional testing as well. An optometrist has gone to optometry school. So optometry school is for 4 years. And then after that, not all optometrists, but some optometrists do a residency as well, a 1 to 2 year residency. And depending on the state, the scope of I guess, care for optometrists varies. Optometrists typically prescribe contacts, glasses. They do primary eye care, again, depending on the state. And depending on the state, some of them can actually prescribe medications as well. For example, eye drops. They can manage basic diseases like early glaucoma, et cetera. And then an optician is someone who actually has a license in opticianry, and an optician has an associate's degree. I think it's about 2 years, and they actually make the glasses and they help to fit the glasses. And then a neuro-ophthalmologist, which is actually what I am, is basically an ophthalmologist who's done additional training. So I did a fellowship in neuro-ophthalmology. It was an extra year of training. And neuro-ophthalmology basically encompasses all the connections between the brain and the eye. So all the cranial nerves that have to do with vision, how our brain processes vision. So I deal with a lot of different neurologic conditions like brain strokes, brain tumors, concussion, autoimmune diseases that affect the eye and the brain, for example, multiple sclerosis, and also thyroid eye disease. So that's also within my my skill set. So in a nutshell, and I also deal with migraines. So that's a big part of what I do as well.
All right. Yeah, that's a big problem as well. A lot of people have migraines and might not relate it to the eyes. So that's good that you mentioned that as well. So, but yeah, so we're going to be chatting about, speaking of thyroid eye disease, we're going to be talking about an integrated approach to thyroid eye disease. And, so what is so why don't you go ahead and explain what thyroid eye disease is?
Sure. So many people don't realize that there is a thyroid eye connection, and the connection is an indirect connection. So basically, when the thyroid gets involved with autoimmune disease, for example, either Graves' disease or Hashimoto's disease, if there are autoimmune antibodies in the body, they can cross-react. Those antibodies that attack the thyroid can cross-react with tissues in the eye socket. So we have in the eye socket, we have the eye muscles, We also have fat in the eye socket and some other soft tissues. So those, the receptors on those tissues in the eye socket look very similar to receptors on the thyroid gland. So these autoantibodies can attack these tissues in the eye socket and cause inflammation. And when there's inflammation, either in the eye socket or even on the lids or the surface of the eye, that's called thyroid eye disease.
All right. So you mentioned it could occur in either Graves or Hashimoto's, even though it seems to be a lot more common with Graves' disease. A small percentage of Hashimoto's patients also has thyroid eye disease, correct?
Absolutely. I think a lot of people, like you said, they automatically associate with Graves' disease, hyperthyroidism, but it can be seen with either. And then there's also a subset of patients who are actually what we call euthyroid, meaning they have normal thyroid function tests, they have normal TSH, free T4, T3, but they have antibodies. And even patients who have normal thyroid function can also have thyroid eye disease if they have the antibodies floating around.
Now, are you talking, when you say antibodies, there's different types of antibodies. So like thyroid stimulating immunoglobulins or
any of them. So TSI, thyroid stimulating immunoglobulin, thyroid peroxidase antibody, thyroglobulin antibody, any of them can potentially cross-react with the tissues in the eye socket.
Okay, that's real interesting. And so what are some of the symptoms that you see with patients that come to your office with thyroid eye disease?
Yeah, so interestingly, a lot of patients don't even know that they have symptoms of thyroid eye disease when they come in, and many of them have perhaps been misdiagnosed as something else because symptoms can overlap with other eye conditions. So I would say the most common symptom is probably dry eye. Many people with thyroid eye disease start off with a feeling of scratchiness, irritation of the eyes, like there's sand in the eye or like a grittiness. And then what can happen is that there can be swelling of the eyelids. So puffiness, particularly of the outer corners of the upper lid, sometimes even the lower lids can get very puffy, very swollen. And then as the disease progresses, there can be redness of the eyelids, redness of the surface of the eye, and also changes in the eyelids. So oftentimes people develop what we call lid retraction, where the lids basically open up wider, and it kind of gives like a look of a stare. We call it the thyroid stare because the eye is just wide open. And it's because the tissues in the eye socket have become inflamed and they become very tight. And so when the muscles get very tight, then the lids open up very wide. Then as the disease progresses, more serious types of symptoms can occur. The next kind of category would be bulging of the eyes. So people can get where one or both eyes may look more prominent, really just very inflamed, their eye socket is very congested. And then if the muscles in the back of the eyes get affected, that can lead to a feeling of tightness, pressure. It can even lead to double vision because the eyes can get misaligned. So if the muscles get very thick and swollen and congested, inflamed, the eyes may, for example, one eye may be higher, one eye may be lower, or one eye may start to turn in a little bit and give people double vision. And then I would say the worst I shouldn't say the worst, but the most advanced form of thyroid eye disease is when there's actually potential loss of vision. And that happens because the nerve, the optic nerve, which is in the eye socket, which is the nerve that connects the eye to the brain, that nerve can get basically compressed by all the congestion in the eye socket, so by the muscles, by the tissues that are all inflamed, and then people can actually lose vision. So that's kind of at the other end of the spectrum, but there's a whole range of symptoms people can have if they have thyroid eye disease.
Okay, and as far as blindness, that's pretty rare.
Extremely rare. So I just want to reassure everybody, yes, it can happen, but it's in less than 5% of people with thyroid eye disease that actually happens. So fortunately, the majority of people don't progress that far. Most people do have with thyroid eye disease, do have some lid changes, puffiness, dryness, surface issues, but not necessarily the other issues that I mentioned. But I did want to kind of give people an overview of all the different types of manifestations thyroid eye disease can have. And unfortunately, because many people come in with puffiness, and especially, seasonal puffiness. So for example, with allergies, like we're right in the middle of springtime right now, people may have puffiness with their lids, redness, irritation. So many people with thyroid eye disease get misdiagnosed as eye allergies or just dry eye. And so they get treated for that for months and months and months, and things just aren't getting better with drops, etc. And ultimately, they end up being diagnosed with thyroid eye disease.
Wow. So you're saying a lot of people think they just have dryness of the eyes, but they really have maybe a more of a mild case of thyroid eye disease? Or
Yeah, yeah. So patients themselves may think that it's something else like dry eye or
Mhm.
allergies, and even doctors, even optometrists, ophthalmologists, there are many physicians who just don't necessarily think of it because there's so much overlap between thyroid eye disease and other, surface issues of the eye. But there are some really characteristic findings that we look for, some very subtle findings that as a neuro-ophthalmologist I really look for, and that is really the lid retraction. So for
Mhm.
example, normally our lids should cover the white part of the eye. So, if you're looking at someone, you shouldn't be able to see on the top and bottom of the cornea, you shouldn't be able to see any white really. But if you can see it white, that means that there's lid retraction, that those muscles are very tight and congested. And that's really one of the earliest hallmarks of thyroid eye disease is that lid retraction.
Okay, no, that's good to know because don't also I also don't want people to panic and think if they're having, because a lot of people do have dry eyes and we don't want them to think that if they
Yes.
have dry eyes or they have allergies that
Right.
definitely, and if they have
Exactly.
Graves' disease, it doesn't confirm, it doesn't
Yeah,
mean
there
anything.
again, if there's overlap, and just because you have some of those symptoms doesn't mean it's from the thyroid, because there are
Mhm.
plenty of people who have Graves' disease or Hashimoto's who never develop thyroid eye disease. So if you're concerned about it, definitely just get it checked out by your eye doctor.
Right, and why do some people, I don't know if you know the answer to this, but why do some people with Graves' disease develop thyroid eye disease while others don't?
I wish I knew the answer to that. That is the big mystery. I always try to ask my patients who come in with thyroid eye disease, were there any triggers? Did something change in your life, in your dietary habits, in your stress levels, in your exposure? Was there anything new that you were exposed to, like a new toxin or something in your environment? And in the majority of people, there really isn't a clear-cut trigger, but I will tell you that the cases I've seen, which are really kind of very prominent, just cases that come on very quickly, many of those patients do report that they're under a lot of stress. So I definitely think that there is some association between stress and cortisol levels and the onset of thyroid eye disease. I mean, I can't tell you how many patients, for example, I had a patient who came in, a young woman who already had other autoimmune diseases. She'd had a couple of other autoimmune diseases diagnosed prior, but she just got married. So she'd been through, planning a wedding and then actually having the wedding. And a week later, she just came in and she had fulminant thyroid eye disease. And it was probably related to that stress that she had gone through just with her life change and her celebration. So
Hmm. Yeah, well, one thing also, just to let people know, if you think your Graves' disease condition was caused by stress, again, that doesn't guarantee that you're going to develop thyroid eye disease. And I could tell from self-experience because, I had Graves' disease in the past, been in remission for quite a while, and stress definitely was a factor in my case. So, and fortunately, I didn't have, at least notice of, who knows, maybe I had a very mild case of thyroid eye disease, but it was never diagnosed. But yeah, stress I think is a big factor with many chronic health conditions.
yeah,
Um,
and I also just want to mention that this is really interesting. The timing of thyroid eye disease doesn't necessarily correlate with thyroid function at all. So, for example, there are some people who have been diagnosed with hyperthyroidism, Graves' disease years ago, and who were under control, like well managed, really asymptomatic from a thyroid standpoint, who maybe 20 or 30 years later may start to develop eye symptoms. So it's very, very interesting. And I wish I knew the answer to what really triggers the eye issues. But it can be very discordant in that way. They don't necessarily run in parallel. And then there are some people who actually develop the thyroid eye symptoms first, and then their thyroid, their TFT, their thyroid function tests, their TSH, free T4, T3 seem to be normal. And then years later, but they do have antibodies, but years later, then they actually develop thyroid dysfunction. So doesn't correlate. And there's really in the majority of cases, there's really no rhyme or reason to it. It's really a mystery, and unfortunately.
yeah, and one thing I have noticed, again, it's not across the board with patients, but the higher their antibodies, especially in the case of Graves with the thyroid stimulating immunoglobulins, it seems like the more likely they are to have thyroid eye disease. Again, I'm not sure if that's something you notice, but if someone has a TSI of, like 300-400, they're more likely, it seems, to develop thyroid eye disease than, a TSI that's like in the lower 200s, for example, or in the upper hundreds. So.
Yeah, I don't know if the actual numbers have ever been looked at, but I've definitely seen it, just clinically, I've seen it where many patients who have very active thyroid eye disease, their numbers are really sky high. And not just TSI, but also thyroglobulin antibodies and anti-TPO as well. And sometimes we can use those numbers to kind of to track them to see how they respond to treatment. So they are useful to follow kind of longitudinally.
Yeah, even though one problem is, at least with endocrinologists, a lot of endocrinologists won't test the antibodies. They just will look at the thyroid, thyroid function test, TSH, free T3, free T4. And it depends on the doctor. Some doctors will do it every single time. Some will just do it initially as to diagnose the person with thyroid autoimmunity. But yeah, I agree. I guess it depends. In some cases, I do, especially, like it seems like more so with the TSI, I do see when someone's improving, it seems like it gradually decreases. Again, there's always exceptions, but sometimes with TPO antibodies, antithyroglobulin antibodies, just again, in my experience, it seems to, a little bit more of a fluctuation where sometimes it'll more of like a roller coaster pattern. But again, that does depend on the person. And do you think everybody with Graves should see get their eyes checked, or you just think if they start experiencing symptoms and they're
not necessarily, no, because as you mentioned, the vast majority of people who have autoimmune thyroid disease, whether it's Graves or Hashimoto's, do not have eye symptoms related to their thyroid. But what I would say is, so for most adults, they should have an annual eye checkup. So just go see your regular eye doctor annually. And if there's anything on the exam, then your doctor may go look further. But there's no need to go rushing to get your baseline eye exam immediately after having the diagnosis.
All right, good deal. So let's go ahead and talk about some of the natural treatments, integrative treatments. So what are some of the things that you recommend from an integrative standpoint for those with thyroid eye disease?
So I would say first and foremost is their diet. Most doctors, endocrinologists, and ophthalmologists alike probably are not asking their patients about their diet, what they're eating. But what I found in many of my thyroid eye disease patients is that they're extremely sensitive to certain types of foods. And they know that when they eat those foods, their eye symptoms tend to flare up, or perhaps they're in remission and then they have a flare up, which is unfortunate. And the food groups that most people are sensitive to happen to be food groups that many people with autoimmune diseases are sensitive to. So it's not just specific to thyroid eye disease, but that includes, for example, gluten. Dairy is huge. I mean, I know some of my patients with thyroid eye disease, even if they have a little bit of hidden dairy in their food, by accident, let's say they go to a restaurant, there's a little bit of cheese in what they're eating, automatically the next day they feel it. They know that they've had something that caused them to flare up. Those are the two that I usually recommend that my patients avoid. Also soy products and nightshades. Those are the main food groups that I recommend that my patients avoid. And then for many of my patients also, particularly the ones who have a lot of lid puffiness, it's important to also be careful around histamine foods, like foods that are rich in histamine. And it's actually interesting. One of my colleagues and I did a study, this was a while back, maybe like 15 plus years ago, using antihistamines for thyroid eye disease. And we found that people who actually took oral antihistamines tended to do better with their puffiness and their swelling, et cetera. Just over-the-counter antihistamines, like even Singulair or Claritin, Zyrtec, can make a difference. So just, from a dietary standpoint, it's important to try to keep a food diary, because what you may be sensitive to may be very individual to you, and it may not reflect what everyone else may be sensitive to. So just try to see if there are certain things that are in your regular diet that you may be sensitive to, and try to experiment and take them out for a few weeks. at least 3 weeks. But sometimes I tell people, if you really want to investigate whether you're sensitive to a certain food or not, eliminate it for a good 3 months, and then try to reintroduce it very slowly and see if you have a reaction to it. I don't know what your experience is with foods and Graves' disease and autoimmune thyroid conditions, but that's been my approach typically.
Yeah, no, I agree. I mean, typically, I don't think there's a perfect diet that fits everyone, but I do have my patients with Graves and Hashimoto's, or at least most of them, start out with kind of like an autoimmune paleo diet. And I always mention it's a starting point. It doesn't mean that, again, there's some people that don't do well with, and that could be the case with any diet, but autoimmune paleo diet, of course, is avoiding gluten and gluten and dairy and soy and the nightshades, but it goes a step further, and like corn or pretty much all grains you're avoiding, and legumes and even eggs, so which a lot of people find challenging. And again, it doesn't mean that everybody has a problem with eggs, but some people do. So it's just a starting point, and then eventually we reintroduce foods. And you mentioned that most endocrinologists don't bring up diet. And not only that, but I've had patients bring up diet to the endocrinologist, and most of them will dismiss it. They won't be open at all to diet playing a role in Graves' disease, thyroid eye disease, and same thing with other autoimmune conditions. Usually they dismiss diet. But yeah, definitely I see a huge difference. And I will say, that being said, diet isn't everything, but it is. What I tell patients is, you could follow a strict, let's say, autoimmune paleo diet or whatever, even regular paleo diet, but good chance you'll notice some great improvements. But sometimes you do need to dig deeper. There could be potentially other triggers, stress you mentioned before, so blocking out time for stress management, and sometimes infections, and we live in a toxic world, so chemicals could also play a role. But how about, no, actually, one other thing before this, it ties into the supplements. So I was going to ask you about supplements you recommend, but the antihistamine. So I don't know if you've experimented with natural antihistamines like quercetin, for example, rather than taking something like Claritin.
Yeah, so I usually recommend that people get it through their foods. If they want, they can take a supplement as well, but I usually recommend quercetin-rich foods like red onions and apples, etc., as an anti-inflammatory, and also turmeric. So curcumin is a potent anti-inflammatory. So I do recommend people add that to their diet. And if they do take a supplement, make sure you take one that also has black pepper, so it helps with the absorption of the curcumin. Now, I just wanted to mention, you were talking a little bit earlier about toxins. And so we know that one of the biggest triggers for thyroid eye disease is smoke and smoking. And so, smoke contains, at least cigarette smoke, probably has over 400 different chemicals in it that get released. And so we don't know exactly which of those chemicals may be triggering the thyroid eye disease, but we know for sure that people who smoke have a much higher, much more aggressive form of the disease, and many of them end up with optic nerve issues and potential vision loss. So going a little bit beyond just stopping smoking cessation and avoiding smoke, I also do recommend that people try to avoid fumes of any kind, even cooking fumes, barbecue fumes. These can be really irritating to the eye. So if you're cooking, I usually recommend that, especially for people who actually have active thyroid eye disease, that they wear some kind of like a goggle or, some kind of covering for their eyes to protect their eyes from that direct exposure to smoke, etc. So I don't know if you've ever heard that before, but it's something that is really important for that. And I think most ophthalmologists do recommend that to their patients. But again, I go a little bit further beyond just the smoking part of it.
Yeah, no, I've not heard about that. I actually did write an article years ago about cigarette smoking and Graves, because in the literature there's also not just thyroid eye disease, but just Graves in general, a greater incidence of Graves' disease in those who smoke. So, but yeah, as far as avoiding other fumes, I did not know. So that again is good to know. And how about other supplements like vitamin D is important for a healthy immune system?
Yeah, absolutely. So vitamin D, I'm sure many people have heard this said, is not just a vitamin. It functions more like a hormone in the body.
Mhm.
It has many different roles in the body, and one of them is immune regulation. And so it is important to have a healthy immune system, having enough vitamin D. And most of us are vitamin D deficient, especially during the colder months of the year. So you want to supplement with vitamin D. And I typically recommend my patients try to keep their vitamin D levels around like 60 to 70. Now, of course, just check with your doctor to make sure that that's okay for you. Some people like to go higher, but if you do go higher, you just have to be concerned about calcium deposition in your coronary arteries, and you don't want to develop heart issues because of high vitamin D levels. But you definitely want to, if you're low or even on the low side, you want to just boost your vitamin D levels. And the other thing, the other mineral is selenium, which I'm sure many people are familiar with when it comes to the thyroid. So selenium supplementation has been actually studied in thyroid eye disease by a European group, and it's been shown to help reduce some of the congestion in the eye socket and the inflammatory response. So for selenium, it's the dose is anywhere from 100 micrograms twice a day to 200 micrograms twice a day is a typical recommended dose.
All right. What would you say about someone who would prefer to get their selenium through foods like Brazil nuts, for example?
Yes, that's a great resource as well. So a handful of Brazil nuts, maybe 2 or 3 Brazil nuts, are a wonderful source. So
yeah, the only thing I will say about that, I brought it up because, again, a lot of people, whenever I bring up selenium, they'll ask about that. And I agree, they're a good source of Brazil nuts, a good source of selenium. But you never know how much you're getting in a specific Brazil nut. So it could be anywhere from like 10 to 20 micrograms, from what I read, at least, to like 70 to 80 micrograms. So yeah, I am of the mindset you want to do as much through food as possible. But honestly, if someone is dealing with active thyroid eye disease, usually I will recommend supplementation. So
yeah, and in terms of the nutrient content of foods, I just also wanted to bring up that our foods, the foods that we get now, they're not grown in the same type of soil that the foods were grown decades ago. So our soil is actually depleted of so many minerals now, just because of changes in agricultural practices. So even though you may think you're having a wonderful diet and super healthy, probably the nutritional value of that produce, both fruits and vegetables, is lower than it really should be. So especially as you mentioned, if you have active conditions, it's probably best to take a supplement. Now, if you're doing well, you probably don't have to take a supplement. But if you actually have symptoms, it's probably a good time to start.
yeah, no, I agree. And even if you eat organic, so it's important to mention too, because a lot of people will be like, well, I'm eating organic, but still, it's still not the same as 10, 15, 20 years ago. So active versus inactive thyroid eye disease. So how long on average, I know it varies, but what do you see as far as active thyroid eye disease lasting?
Yeah, so the active stage of the disease is when people actually have a lot of congestion. So their eyelids, their eye sockets, that's when people develop the bulging, or it's what we call proptosis is the medical term for bulging of the eyes. That is it usually lasts anywhere from 2 to 3 years, probably closer to 2 years in most people. And it's very difficult for patients during this time because they're uncomfortable. Their vision is affected. They see blurry because of the surface issues, the dryness, etc. They have pressure. They may see double. And what people need to realize is that you have to wait the active phase out. And of course, there are things you can do to try to modulate that, but it does run a course of about 2 years, and we really have to be patient. And then the disease usually kind of, some people call it like it burns itself out. It doesn't really burn itself out, but it basically becomes stable. And then a lot of the edema, the swelling, starts to go away. And so then the puffiness kind of resolves a little bit. Sometimes the bulging improves as well, and then people may have what we call, again, the stable some people call it the fibrosing stage of thyroid eye disease. Fibrosing basically means that it's scarring, but it doesn't necessarily have to be scar tissue. It's just not as actively inflamed and edematous as the active phase was. But I think education is really important in just kind of setting people's expectations that, okay, it's active right now. Let's see how things are going to go. And it may take a few years before things really start to quiet down.
How about conventional treatment? So you spoke a little bit about diet and supplementation. When is conventional treatment necessary for thyroid eye disease?
Yeah, so really when there's a risk of vision loss is when as ophthalmologists and neuro-ophthalmologists, we become very concerned. And there are a couple of different mechanisms where people can develop vision loss. So one is optic nerve compression, what I was saying. If there's a lot of congestion in the eye socket, the optic nerve can get compressed. People can have peripheral vision loss, central vision loss, color loss. So that's definitely an indication for medical treatment. Also, if the eyes are very prominent, if they're really bulging and the eyelids just can't close properly, then the cornea can get very dry. And it can get so dried out that you can actually develop corneal ulcer because the cornea is just not lubricated properly. People can develop infection, which is an ulcer, and even scarring. So that is enough. So those are the two real main indications for when medical treatment is really indicated, and usually in an emergency type situation. And I like to kind of tell my patients, well, I approach this as in an integrative way. So yes, of course, we're going to try the nutrients, the nutrition first, and the supplements, and the conservative measures like using drops and using cool compresses and using humidification and essential oils. We're going to try all of that. But if it ever gets to the stage where your vision is at risk, we're not taking any chances. And in that situation, then yes, it really is so important to be started on an agent that will help to decrease the swelling and protect your vision. And the typical treatment is steroids. And I hate to say that, but that really is, that really is, unfortunately, we don't have anything. Well, I'll take that back. So we do have something which we can talk about, but prednisone in the acute setting is really what's necessary to help preserve the optic nerve. And in cases where people have actually lost vision or significant vision, we actually sometimes admit them to the hospital and put them on 3 days of IV steroids. If it's not so bad, we may just try oral steroids first, just to get the swelling to go down. And then, people can be tapered off the steroids over time. But that's the up until now, that really has been the mainstay of treatment. And then sort of recently, actually last January, the FDA approved a medication. This is really the first FDA medication for thyroid eye disease, specifically for thyroid eye disease. It's called teprotumumab, which is Topeza, and it's a biologic agent. Biologic basically means that it helps to modulate the immune system. And what it does is actually, so what happens in thyroid eye disease is that a particular receptor gets activated called insulin-like growth factor receptor, IGFR. And so Topeza blocks that receptor. So it blocks that activation. So a lot of the changes that happen in the eye socket don't happen. So Topeza is given as an infusion. It's usually given over the course of 24 weeks, basically 8 treatments every 3 weeks, so 24 weeks of treatment. And for patients with really active disease where they have significant vision issues, maybe double vision, a lot of bulging of the eyes, swelling of the eyelids, it really has been extremely useful, and in many patients really transformational for their care. And again, I remind patients that yes, we try to approach things naturally whenever possible, but in some cases we do have to really rely on our medical treatments and a little bit more aggressive treatment. And so it is part of the toolbox, and it is just something to consider, and maybe have a discussion with your ophthalmologist about, or your neuro-ophthalmologist about, if you may be a candidate and if things are not responding to natural treatments.
And that currently, as far as I know, it's only available in the United States? Or?
I think it's available in other countries as well. I do want to say it's available in Europe.
Okay. At least Canada, I don't think, I mean, there might be other biological agents in Canada, but I thought it was.
Yes. So I'm not sure about that, about other countries, but one interesting thing that happened in the US was, so the drug got approved in January of 2020, and then the COVID pandemic hit. And then once the vaccines were being manufactured, the factory where they actually made Topeza had to switch over. So it was mandated by the government to switch over to making the COVID vaccine. So there became a shortage of Topeza in the country for quite some time, actually. And it wasn't until just actually, I think about 2 weeks ago, that it became available again. So there were quite a few patients who were actually mid-treatment who actually had treatment.
I had one of those. I've had a few patients. One of them was able to complete the course, fortunately, but then another one, had to get it interrupted, so which was unfortunate. But
yeah, and we don't know now, if you've been in that situation where you've not been able to get the medication, whether you basically have to start again from scratch. I'm not really sure kind of how that would work, but the other medicine, it's also a biologic that has been used for thyroid eye disease, is something called rituximab or Rituxan. And that's actually a much more widely available drug. It's also given as an infusion, but it's given every 6 months. And so in countries where Topeza may not yet be available, Rituxan is kind of the next best option.
All right, now that's good to know. And then with Topeza, is it I haven't had a lot of patients get it, just a couple so far, but one person who was able to complete the course said that it greatly helped with the bulging, the lid retraction, but really didn't help with the double vision. So I don't know if you've seen that or if it, again, just varies depending on the person.
Yeah, so the clinical trial actually looked at the primary endpoint was bulging. So Topeza helped improve bulging by, I think it was about 3 millimeters or so. But they found that there was some improvement in the double vision, but not enough to be, fully restorative in terms of resolving the double completely. And ultimately, if you, let's say, if you're a candidate for Topeza and you do Topeza for 24 weeks, your doctor will assess, how effective it was. And then some people actually need a second course of the drug. So it's now actually available as a second course. And also, for initially with the study, they looked at patients who were only in the acute phase, only within 9 months of having had symptoms. But now I think there's a recent study that was published that showed that it's also effective for people who have chronic thyroid eye disease. So in that stable progressive phase, you may still be a candidate for Topeza, with the hopes that, with some improved swelling, congestion in the eye socket, that maybe the double may improve as well. But the double can be quite challenging to manage. Clinically, we always start with the most conservative therapy there is, which is prism therapy. And I'm not sure if your audience is familiar with prisms, but prisms are basically, they're optical devices that you can put onto glasses, and they basically realign the image onto your eye. So it's not realigning the eye itself, but it's realigning the image so people don't see double. So that's very effective for many people to use a prism. But ultimately, if the prism doesn't help, and also as things kind of stabilize, if people still have double vision, then a surgery may be what's really necessary to get rid of the double vision. But that's kind of the last resort. Surgery is really not something that we think of unless people are very refractory, they're not improving to other standard treatments.
Okay, and surgery typically is not done in the active phase, correct?
Absolutely not. No. For double vision, so my typical rule of thumb is, first of all, I work with the patient's endocrinologist to make sure that their thyroid is stable. So once their thyroid is stable, and if they're on medication, once that's stable for at least 6 months, then the clock starts ticking. Then I wait another 6 months to make sure that their double vision is stable also. And the reason is because if someone has double and we operate too soon, and things are still changing, they're dynamically changing in the eye socket, then that surgery may become ineffective because the double may come back or it may go the other way. So it really is important to make sure that everything is 100% stable before having any kind of surgery for double vision. So patience, it's really challenging, and it's really difficult for some people to have to know that they have to wait that long, but really it's in their best interest that they should be waiting.
Okay, no, it makes sense. And so I think this might be my last question. Radioactive iodine. So radioactive iodine, it seems like in the research, there is a little bit of controversy, but it seems like it can potentially cause or exacerbate thyroid eye disease. And so a lot of endocrinologists won't recommend recommend radioactive iodine to their thyroid eye disease patients. So where do you stand on whether someone or not should receive radioactive iodine if they have thyroid eye disease?
Yeah, so what happens with radioactive iodine is basically the thyroid tissue is destroyed, and a lot of thyroid hormone is released, and also the antibodies are released. And that can actually create a thyroid storm in some patients. But even if they don't have a thyroid storm, if you have a sudden release of a lot of hormone and antibody, the antibodies can again cross-react in the eye socket and trigger active thyroid eye disease. Whether they have it before or not, the patient may suddenly develop eye symptoms. So what I do is, I basically let the patient know that they should really work with their endocrinologist to first decide what treatment is best for them. Should they be on a medical agent like methimazole or PTU, or do they really need radioactive ablation? If they do, then what I usually recommend is a short course of steroids starting 1 week before and 2 weeks after to prevent any exacerbation or activation of thyroid eye disease. And I dose it based on the patient's weight. So basically, what I do is I take the patient's weight in kilograms. And so let's say somebody is 70 kilos, you take half of that, so it'd be 35, and I give them 35 milligrams of prednisone starting 1 week before the radioactive ablation and continuing 2 weeks after. And then that's it. Then they don't need any more. So that kind of carries them through and covers them for that time. And I have to say, knock on wood, that with that regimen, in all my patients, and I've seen thyroid eye disease patients for well over 20 years, none of them, knock on wood, have had activation of their thyroid eye disease after having had RAI. So it's just something to consider, and make sure you talk to your doctor about it, whether they're in agreement and they can maybe prescribe it for you if you really need to have that radioactive iodine.
Okay, no, that's interesting. And again, I try to encourage people if they can. Obviously, I can't tell them what to do and what not to do, but in my opinion, in most cases, radioactive iodine should be like a last resort. Radioactive iodine, thyroid surgery. So my goal is to try to address the cause of the problem. But I think it's important to talk about both sides because sometimes conventional treatment is necessary. So I just wanted to get your opinion on that.
Yeah, I agree completely. If you can manage it naturally, that's the best way to do it. But at some point, if it's really causing a detriment to your health and it's not being well controlled with other treatments, then yes, an intervention is necessary, either thyroidectomy or partial thyroidectomy or RAI. And the same holds true for surgery. So I do the same for my surgical patients. I put them on steroids for three weeks before and after.
Oh, you do? Okay.
I do the same thing. Mm-hmm.
Okay. So same routine, whether it's surgery or radioactive iodine. Okay.
Mm-hmm.
All right. And now one more quick question that's related to this. Is it only if they have, because how about if someone can't someone have mild thyroid eye disease but not know it? So do you just recommend it if they have overt thyroid eye disease, or as far as
even if a patient has been seeing me and I know that they have mild thyroid eye disease, I would absolutely recommend the prednisone. Mm-hmm. Yeah. And I guess what you're asking about is, what if they haven't been formally diagnosed?
Correct, yeah.
It's probably best that, if you're considering getting it done, or if your endocrinologist is recommending it, go see your eye doctor, and again, see your ophthalmologist, and preferably a neuro-ophthalmologist if you can get in to see one, and just get their their opinion on whether it's active or not. And if there's any indication it's active, it's probably best to be pre-treated.
All right, great advice. Thank you for that. And yeah, this was awesome. Thank you for all the information. And so before we dive into questions, I want you to briefly mention your masterclass that you'll be having. And I'll put up here, just if I could display it here. There we go. Oh,
Yeah, wonderful. So thank you. I really enjoyed our conversation, and there's just so much to talk about. We could probably keep talking for an hour or so about thyroid eye disease. But so what I'm going to be offering is a masterclass, the thyroid eye disease masterclass, or an integrative approach, where I talk about, specifically what are the signs and symptoms of thyroid eye disease, what are the natural ways you can try to combat thyroid eye disease. I actually, in my practice, I use something called the thyroid eye disease diet, or TED, TEDD. So I share that, be sharing that in the masterclass. Also, the specific types of supplements and botanicals that I found to be most effective for people with thyroid eye disease, as well as some of the essential oils that I use for my patients. In terms of dry eye, what are the best natural therapies for dry eye? Beyond just using drops, lubrication, what else can you do in your home environment to help with thyroid eye disease? And then also just talking about some of the more medical treatments that we touched upon a little bit today. What are the indications? What are, just others, also lifestyle things you can do to decrease your risk of activation or worsening of thyroid eye disease. So I'm going to be offering this along with Dr. Eric. We're going to hopefully do this together as a single masterclass. There's only one module, and it's going to be on tentatively on June 23rd, which is a Wednesday at 8 p.m. Eastern. And hopefully, if you're interested, you can register. And if you're watching this and you just do decide to register, we are offering a 50% off discount. So the normal price of the masterclass is $99. So then it would be about $48.50. So if you can go ahead and register, I think we're going to have that available for the next week or so. Is that right, Dr. Eric?
Yeah, I think we decided on a week from Friday, May 7th, until the end. Yeah. So, or actually, today is Friday. That's right. So a week from today.
A week from today, yeah. And if you're interested, please register early. There is limited capacity. There's only 100 participants that we can have in the masterclass. So please consider registering.
All right. Wonderful. Wonderful. Well, you're ready to answer some questions? Looks like we have a lot of questions.
Absolutely. Okay, wonderful.
All right. And one other thing about the class also, if for any reason, if someone is unable to make it, it's hard to pick a time. I know that works for everyone, but this will be recorded. So if for any reason they can't make it, they could always, watch the recording. And
absolutely. And also we'll make available downloadable PDF resources. So not just the thyroid eye disease diet, but my resources on how to manage dry eye, eye allergies with thyroid eye disease, digital eye strain, which is, I know, big concern of many people is we spend hours looking at a screen. So how can we help to manage that with thyroid eye disease? So there'll be a lot of resources available.
All right. Good deal. Looking forward to that. And all right, so let's go and we'll try to get to as many questions as we can. All right. So Tammy, it looks like myasthenia gravis. Do you have any experience in your practice?
Absolutely. I'm so glad, Tammy, that you brought this up because for people who are not familiar with myasthenia gravis, it is also an autoimmune disease. And myasthenia and thyroid go hand in hand, or at least thyroid eye disease and myasthenia go hand in hand. What myasthenia does is it can cause double vision and it can cause droopiness of the lids. So opposite of what thyroid eye disease does. So thyroid eye disease causes wide open lids, myasthenia causes drooping. So a certain percentage of patients with thyroid eye disease will have coexisting myasthenia, and a larger percentage of patients with myasthenia will also have thyroid eye disease. And so definitely if you have any of those symptoms that are a little bit unusual for just thyroid eye disease, ask your doctor about whether it could be myasthenia or not, and get tested. So myasthenia, there's a couple of different ways to test for it. There's a blood test looking for the antibodies. That's the easiest way to test for it, but there are many people who have myasthenia where it affects the eyes, where their blood test is negative, and we have to go a little bit further. We have to dig a little bit deeper to figure out if someone has it or not. And the last thing I'm just going to mention about myasthenia is that it tends to affect, it causes weakness of the eye muscles, and that's called ocular myasthenia, or OMG. But there's also a chance that other muscles in the body can get affected by myasthenia gravis as well. So your arms, your legs, breathing, swallowing, voice. So definitely, if you have any symptoms of weakness and you have a history of thyroid eye disease, definitely talk to your doctor and consider getting tested for myasthenia.
All right, great. Thank you for that. And then May here has a question. Do you have any advice for tearful eyes?
Yeah, so there are many reasons why your eyes may be tearing. And actually the most common reason is because the eyes are dry. And it may seem very contradictory. You know, why are my eyes tearing if they're dry? That just doesn't make sense. But I'll explain to you why that is. So first of all, what happens is the surface of the eye dries out. And then we have a large tear gland up here called the lacrimal gland. And in response to that dryness, it overproduces tears. So people end up tearing when they have dry eye. So the way to deal with the tearing is to first treat the dry eye. And if you do that appropriately, then usually the tearing also improves as well. But then again, with thyroid eye disease, there are many other reasons why people may have tearing. For example, eye allergies can also cause tearing. And then just swelling of the surface of the eye can also cause tearing, and even mucus discharge. So a lot of other things can happen with thyroid eye disease that people should be aware of.
All right. And then Jenny, I don't know, you might have to clarify. I'm not sure if you mean thyroid hormone levels or sex hormone levels. But anyway, if you can maybe further elaborate with if Jenny could elaborate. But then, so Pilly here, can you have thyroid eye disease and not be sure which to answer? You know, we kind of answered that early on. If someone can have a mild case and it not being diagnosed, correct?
Yes, and the best way to make the diagnosis is to get those thyroid autoantibodies done and really advocate to get them done. So your endocrinologist may say, oh, we don't need them, you know, we just need these you know, TSH-free T4, T3, but I would really strongly push to get the rest of the antibodies done because that will confirm the diagnosis.
All right, great. So this is a bit of a long one. So recently being diagnosed with Demodex in my eyelids. Do you think this could be a sign of TED? Also, do you know how long it could take for Demodex to go away? Can it spread to my scalp, nose, or other parts of my body? So maybe, I don't know if you could.
Sure. Yeah. So Demodex is basically an infestation of the eyelids of really lice. So we can get lice around the follicle, the hair follicle of the eyelash. And so it's independent of thyroid eye disease, but it can certainly cause irritation, inflammation. The best way to actually treat it is to really just smother the infestation. So basically you just goop up your eyelids at nighttime with an ointment, whether it's just a regular ointment, eye ointment, or an antibiotic ointment. And it basically just gets rid of those organisms.
Okay. All right. Great. All right. Just a comment here. After miscarriage of my twins, I developed Graves. I'm so sorry about that. And then Jenny, I took an allergy test and histamines showed positive. And yeah, and you mentioned earlier how sometimes the antihistamines can help with thyroid eye disease.
Yeah. One other thing, you know, as an integrative practitioner, that I also try to do for my patients is I do order food sensitivity testing. Because sometimes it's really hard just to do a food diary to try to figure out what you may be sensitive to. And so sometimes it's actually good to get a whole panel done. So that way you really know which foods you should try to stay away from. So this is not IgE testing, this is IgG testing. So I would, again, advocate for that, you know, talk to your practitioner about it, ask if you can get it done. And it really will kind of give you a lot of insights into the foods that your body may be sensitive to. I don't know if you did that at Dr. Eric in your practice, but I found it pretty effective.
Yeah. I mean, I have done it. Sometimes I'll do it. I usually, every practitioner is different. So, I usually start people off with an elimination type diet and, do like an elimination reintroduction. And it's not perfect. I find IgG testing, also, I don't think there's any perfect test or perfect method, but I usually reserve it if someone's not improving and we're because we usually, with the part of an elimination diet, we're having them eliminate pretty much just all the common allergens and things that could be causing inflammation. But of course, there's always exceptions. Someone could be still reacting to something that they haven't eliminated. And speaking of food, so this person asked, why nightshades? I don't know if you want to talk about it or if you want me to talk about it.
So I'm not an expert in why nightshades. I mean, I have my theories, but I would love to get your opinion on it if you have some insights.
Yeah, and there's also an article. If you visit my article, my website, naturalendocrinesolutions.com, do a search for nightshades. But essentially, there's compounds, there's lectins and other compounds in the nightshades that potentially could be inflammatory. They're not inflammatory necessarily in everybody. They can also potentially interfere with gut healing. And when someone is dealing really with any chronic health condition, but especially with autoimmunity, you really want to focus on healing the gut. So, but that's the main reason why you want to avoid nightshades. And let's see if you see anything as I scroll down, but it looks like a lot of these are just comments and not questions. So Stacy, what's good for the pain? I have terrible back pain from fibromyalgia. So yeah, it's a little bit not necessarily related to the topic, but inflammation's huge. So you want to, with fibromyalgia, also nutrients, mitochondrial dysfunction, which are nutrient driven. So just making sure that again, as we were discussing before, sometimes even though you want to try to eat whole healthy foods, in my experience, when someone has nutrient deficiencies, usually supplementation is required. And then Dr. Rani mentioned other things that could help with inflammation, like turmeric, curcumin, CBD oil. A lot of people are using. But with that being said, you also want to address the cause of the problem. So why is it a nutrient deficiency? Do you have a chronic infection? Are you eating an inflammatory food such as gluten or dairy? So there are things that you could take, like the curcumin, like the CBD oil. And there's other things you could take for pain. But again, also you want to try to address what's causing the pain. All right, and then how much vitamin D daily? And this does depend. In my practice, and most practitioners will test vitamin D levels, 25 hydroxy vitamin D, and then based on the results. And then, as Dr. Rani says, like I like to see it minimum above 50, but some like to see it between 60 and 80. So, and my level is usually upper 50s, lower 60s. And as Dr. Rani said, you don't want it to be too high. So probably a good idea to, work with a practitioner just to make sure you're not taking too much vitamin D. And then, of course, try to get as much sun as you can as well. All right. And all right, well, this person, the salt question. So, I usually recommend, I think Celtic sea salt is fine, natural sea salt. Pink Himalayan salt, for years I've mentioned that it was fine, but then recently there's been a book that says that pink Himalayan salt is higher in iodine, which so I'm not sure, but so everyone is different. I've had people take pink Himalayan salt without a problem, but Celtic sea salt seems to be pretty safe to take.
Yeah. I'll just add a comment about salt intake. I do notice that when my patients do report that they're on high salt diets, that their eyelid swelling is worse. So I usually do salt restrict my patients if they have active graves, just as an aside, since we're talking about salt.
Interesting. So even like sea salt, you'll have them.
Yeah. Okay. And especially people will notice it, like especially after they've been sleeping, they tend to have a lot of, because they're lying flat, And so all that congestion, the fluid accumulates in their lids. So it really kind of is more puffy. But then when they reduce their salt intake or eliminate it completely as much as possible, then they have less swelling in the morning. So it's just something you can experiment with, is to, see how your salt intake may impact your thyroid eye disease.
Yeah. And besides, like the sea salt, there's salt in everything. Like if you brought anything that's packaged or processed, I mean, if you're buying fresh fruits and vegetables, you don't have to worry, but anything that pretty much comes packaged will have sodium. So that's also worth mentioning as well. And then how are you, by the way, Dr. Rani, how are you on time? Do you have a few minutes?
Oh, yes, I can. Yeah, I'm good.
Okay.
Good. Yeah.
All right. So here says, I've read that selenium supplementation can make iodine deficiency worse. With that in mind, although high dose iodine can aggravate Graves' disease, do you recommend that Graves' disease patients who want to try selenium for thyroid eye disease also supplement with a small? So I'll say, and I love to get your feedback. But I will say that, I mean, there's definitely a lot of controversy with iodine and thyroid health. So, I was one of those that was on the bandwagon years ago. Like I took high dose iodine and I did fine. I did really good with iodine. So I was one of those people that was able to tolerate it well. And, early on my practice, I would have everybody do urinary testing for iodine. And if someone was deficient, would put people on iodine. And a lot of people did okay, but not everybody. Sometimes it does seem to make people worse. And again, I've written about this in articles as well. So I'm not anti-iodine, but I'm definitely cautious when it comes to iodine. So even if someone's deficient in iodine, which again, the testing, like if someone does a blood test, for example, even the urinary test, there's some controversy, but even if they're deficient, I'd be a little bit cautious about having them supplement with iodine. But especially just, like randomly take iodine. I can't say it's something I recommend to my patients, but again, I'd like to hear what you have to say.
Yeah, I also typically don't recommend it. If it's naturally present in foods, then that's fine, but I wouldn't take an extra supplement. Now, in terms of the other question, I think maybe she was getting at whether the iodine could be a competitive inhibitor of selenium. I think maybe that was
Okay,
kind of what the question was. I don't know. I don't think that they have the same function in the body. Selenium has many different functions. So I don't think that they would be a competitive inhibitor of each other. So
I would agree. Yeah, I kind of skipped over that. But yeah, so it's I haven't heard where taking selenium will worsen an iodine deficiency. So yeah, and all right, and someone is using eye pressure drops, it looks like, or
yeah, so I'll just talk a little bit about eye pressure if we have a few minutes.
sure.
So one of the other manifestations of thyroid eye disease is because there's so much pressure, congestion in the eye socket, the eye pressure can go up. And that's eye pressure is different than blood pressure. It's actually the pressure within the eyeball itself. And so many people, it's something that we worry about because if their eye pressure goes up, then they can have damage to their optic nerve or a type of glaucoma. So certainly if you do have orbital symptoms or eye socket symptoms, get your pressure checked by your eye doctor. If it is elevated, then sometimes, or if it's quite elevated, usually in the 30s or so, we do start patients on drops. And hopefully, once their swelling improves, their congestion improves, patients can come off the drops. But it's more of a protection that patients need the eye drop for.
Okay, cool. Thank you for that. All right, how about this? I don't know. Would you recommend Topeza if proptosis is only 2 millimeter difference?
So it's FDA approved for greater than 3 millimeters. So 2 millimeters is actually, I'm glad you brought this up. It's actually within the range of normal. Many normal people have a difference in their eyes of 2 millimeters, but 3 or more is typically what we attribute to thyroid eye disease. So right now there's very strict guidelines on whether insurance carriers will cover Topeza, and one of those guidelines is the amount of proptosis or the asymmetry in proptosis.
All right, thank you for that. And then can you talk about the pros and cons of Topeza versus Tomexa, the second infusion option that was just mentioned?
Sure. So the second infusion option is Rituxan. It's Rituxan or rituximab. So rituximab has been used. It's a slightly different uh, biologic. It works on B cells. It's a CD20 inhibitor, and Rituxan has been used for many, many years. It's been out there for many years for many different inflammatory conditions, ranging from a lot of eye conditions that we use it for. It has more data behind it in terms of its actual benefits for thyroid eye disease. It's never been formally studied head to head with Topeza, so we don't know, is one better than the other? They've been independently kind of looked at in clinical trials. So again, we can't really answer that question whether one is better than the other. But in terms of side effect profile, I think Topeza has a very low side effect profile. Probably Rituxan has a couple more side effects, but it is less frequent. So Topeza is every 3 weeks versus Rituxan is every 6 months. So there's a big difference in terms of the frequency of the treatment.
So a single infusion every 6 months?
Single infusion every 6 months. There's a first dose, and then 2 weeks later, there's a second loading dose. But then after the second dose, it's every 6 months.
Okay. Does everybody need that? Like after 6 months, a lot can change, or
A lot can change, yeah. So usually people need, maybe 1 or 2 cycles of it before they start to respond. So, but then there are other conditions where people need it, really indefinitely every 6 months. There are other autoimmune conditions that I manage, that deal with, that affect the eyes where people do need it a lot longer.
All right. No, thank you for that. And it's just someone thanking you for the.
You're very welcome. Thank you for tuning in.
Yeah, no, we appreciate everyone tuning in and asking questions. And then Julie here, I had very mild thyroid eye disease when I had 2 doses of radioactive iodine 5 years ago. It has become very active and much more severe. What can I do to help it?
Yeah, so it really depends again on what your specific symptoms are, whether it's puffiness, whether it's bulging, double vision, dryness. So certainly talk to your doctor about the stage that you're at, whether it's still in the active phase or maybe now, hopefully after a couple of years, if this all started 5 years ago, hopefully it's becoming a lot more of in transitioning into that more quiescent chronic stage. Talk to your doctor about the options, whether it's drops, supplements, or something perhaps a little bit more involved, like either medications or even surgery may be an option for you. But I would also suggest, perhaps considering taking the masterclass that we talked about, because I will kind of talk about, okay, for this stage, these are kind of the best options. And then if it progresses to this stage, these are the best options, and then so on. So I will break that down in the masterclass.
Okay, great. I'll bring that up quickly again. You're good for maybe like another 3 questions?
Sure.
Okay, great. So, all right. And again, Jenny is just saying thank you, and thank you, Jenny.
Thank you. You're very welcome.
All right. Let's see. So Deborah had radioactive iodine 2 years after thyroid eye disease Graves diagnosis, PTU. Methimazole sadly didn't work for remission. Liver could be damaged at 2 years on these meds. Took prednisone before radioactive iodine, and after the largest radioactive iodine dose allowed without hospitalization, helped reduce more bulging, then waited to have 6 reconstructive surgeries in 2 years. Wow. Still get Kenalog injections instead of Orbit when they swell or hurt years later, like steroid direct into affected area, then oral steroid pill and bounce to.
Oh, I'm so sorry to hear that, Deborah. Yeah, you've been through so much. Again, I haven't examined you, I haven't seen you, but from what you're telling me, it seems like it's still active despite having the surgeries and the steroids, et cetera. You may be a candidate for Topeza, even though it's been some time. So definitely talk to your doctor about that option, just to get everything, to calm down, because there's still some activity there, it sounds like. Yeah, and it's not great to keep getting Kenalog injections into the eye socket, because that type of a steroid injected into the eye socket, it can cause problems. It can actually lead to high eye pressure, glaucoma, even thinning of some of the muscles in the eyes. So definitely talk to your doctor about the options.
Right. Yeah, I was just going to ask you about the Kenalog injections, but you kind of answered the question. So very cool. All right. And then, so let's see, we'll go through 2 more questions. So my thyroid peroxidase, anti-TPO levels are 154, not the best, but I managed to lower them. Before they were 195. Still, my right eye is bulging. I know when my levels are not normal because my right eye lets me know right away. Yeah. So again, I will say, and Dr. Rani could also give her feedback, but just of course, I don't know what you did to, as far as lowering them, but just, as far as, try to do as much as you can through diet and lifestyle. Again, maybe attend the master class as well, and Topeza might be an option as well. But again, I think even with that, it's, I will say with the Topeza, it's again, you want to, I would say probably more for moderate, severe cases of thyroid eye disease, and then also from what I understand, it's also very expensive for those who don't have insurance too. So even if some have so it's not an option for everyone, unfortunately.
So just to provide a comment there. So it's wonderful that you're so in tune with your symptoms. Many people, they may dismiss certain symptoms, but it's wonderful that you're in tune and that you can tell from your eye status what your antibody levels are. So it's really just I applaud you for that, because it's important to just be aware. That way you can convey to your doctor what's going on better, and hopefully get treatment that you need if necessary. And I also just want to say about the Topeza, so it is expensive, and it's estimated that one course of treatment costs $200,000. So that's 8 infusions. And I don't know whether the price will be going down at any time in the future, but right now it is at that level. So it is sometimes challenging for patients to get the authorization that they need to get the medications. But I do think that the company offers some patient assistance programs. So certainly if you qualify based on the criteria, I didn't mention this earlier, but I just wanted to show you all. So I don't know if you can see this here. The CAS score is Clinical Activity Scale, and basically it's a guide here. I don't know if you can see here. I'm not quite centered here, but there's a rating scale that we use to really determine how active a person's thyroid eye disease is. And really for Topeza to be approved, people have to meet some of these criteria based on their CAS score or worsening of their CAS score. So it is something that again, you can talk to your eye doctor about assessing that score to see if you may qualify for Topeza, and also whether your insurance will cover it or not.
All right. And we were chatting a little bit before this. Did you want, I could also include that sheet as well when I send
Absolutely.
out.
Yeah, so I will, I'll scan this in and create a PDF of it, and then we can include that with the link to the live.
Yeah. Let's see, and then let's get to one more question. So Lily here, and again, if we didn't get to your question, I am so sorry. But we might do another one of these in the future. But again, definitely consider joining the master class. And so Lily here, hello, Dr. Banik. Thank you for taking my question. I was diagnosed with Graves' disease in 2018 and had my very first symptom, which was thyroid eye disease. Before I had bulging eye in the left. I developed heavy eye bags below my eyes first. My blood test has been normal, the T3, T4, TSH for a year now. So my bulging eyes has gotten better, but the heavy eye bags are still there. Are the cause for the bulging eyes the same cause for the eye bags? And will the eye bags improve later, or will they not?
Yeah, great question. So many people actually experience this, where it's not just the lids that get puffy and swollen, but they actually develop bags And what the bags are actually fat pads. We have fat pads in the eye socket to help just cushion the eye, the eyeball, etc. So those fat pads get inflamed with thyroid eye disease. And it's all due to that insulin-like growth factor receptor being activated. So there's a lot of tissue that gets laid down in those fat pads and makes them very prominent. Now, what I'll tell you is that after the active phase of the disease improves, many times the fat pads do decrease in size, but they may not go back 100% to how they used to be, how you used to look. I've actually only had a handful of patients where they actually went back to their normal, pre-thyroid eye disease state. So, sorry, sometimes the fat pads do persist. And in that case, again, some of the natural treatments that we talked about can be effective. And ultimately, sometimes there is a surgery that can be done to actually remove the fat pads or to decrease their volume to help people just have a better cosmetic appearance. And we didn't talk about this aspect as much about thyroid eye disease, but the cosmetic changes can really be for some people, really, really difficult to manage and very debilitating. And just, their self-image is just so affected by the cosmetic changes. But there are wonderful treatments out there for the cosmetic treatments. Now, of course, many of them are surgical options, whether it's lid surgery or something called blepharoplasty, where sometimes the skin and the fat is removed, or strabismus surgery, which is where the eyes are realigned. There are many cosmetic options out there, even orbital decompression, which we didn't mention at all, but it's basically a surgery to remove some of the bone to help the eyes go back into a more natural position. So those are all extremely effective treatments. Now, of course, they are surgeries, so they're not taken lightly and they have to be timed right, but they are wonderful options to help to restore cosmesis and improve people's appearance, make them look more, similar to how they used to look before they had thyroid eye disease.
All right. No, thank you. Thank you for mentioning that. And again, thank you so much for this interview, for getting together for this Facebook Live. And yeah, hopefully everyone found it valuable. And again, consider attending the masterclass if you're dealing with thyroid eye disease. And again, it's you could just visit thyroideyediseaseclass.com. And until next Friday, a week from today, Friday, May 7th, though you could get a 50% discount by entering the code TED. And I assume during that class, we'll also be doing some Q&A.
Absolutely. Yes. Yes.
Right.
So we'll do a didactic session and then we'll stay on for Q&A as long as people have questions. So happy to answer all your questions. And thank you for having me. Really, I enjoyed our conversation. I think we covered a tremendous amount, which is amazing. And I loved all the questions people typed in. It's really wonderful to make this an interactive session. So thank you for having me.
Yeah, no, you're welcome. It was great. And yeah, and excited for the masterclass. And again, maybe in the future we'll get together for another Facebook Live. So yeah, definitely had a lot of interest, a lot of questions. And again, apologize for the questions we didn't get answered, but definitely if you can show up to the masterclass, and we'll, as Dr. Rani says, we will have a Q&A session there as well. And well, anyway, everyone, hope you have a wonderful Friday, a wonderful weekend ahead. And again, thank you so much, Dr. Rani, for getting together.
Thank you, Dr. Eric. It was my pleasure.
All right. Take care, everyone.
Bye-bye.